Hi, my name is Justin Ulrich. I am the Institutional Director at Middle Tennessee Cardiovascular Institute. I'm an advanced cardiac sonographer and a fellow of the American Society of Echocardiography. Today we're going to be talking about the views associated with a basic full transthoracic echocardiogram. Now there are four windows that we use to obtain each of these views we're going to be talking about. We're also going to kind of look into a little bit of how we place the transducer on the chest, how we rotate the transducer to obtain these views, how we tilt, how we slide, medial, lateral, those types of things. We're also going to look at the ultrasound beam and how it transects the heart, anatomically speaking. We're going to look at the heart sitting inside of the chest, and we're also going to kind of compare what we're seeing on our ultrasound machine screen to what we're seeing anatomically as the heart is placed in the chest. What we see on the screen is very different, and so we're going to compare the two and kind of be able to flip that anatomy around to show you why we're seeing what we're seeing on the screen. In addition to that, we will describe the anatomy that we're seeing in each of the views we obtain as well. So first off, we're going to start with a parasternal long axis window of the left ventricle here, okay? So several things. On the left side of our screen here, we are essentially seeing the heart as it sits in the chest itself. So up here, this is the left side of the heart. More anterior to us is the right side of the heart. So we've got the pulmonary artery branching up here, and we've got the aorta kind of looping underneath that here, coming up here. So again, left side of the heart, right side of the heart here. We refer to this area as the base of the heart, kind of the top portion of the heart. And we refer down here, this bottom portion, as the apex of the heart. So base, apex. Now, this is as the heart's sitting in the chest. What we're seeing up here is what we see on our ultrasound machine screen. So I want you to think of our ultrasound transducer sitting up here looking this way at the heart. Okay, so this would be considered the near field of our ultrasound beam. This would be considered the far field. So if you think about this, our transducer is sitting right here on top of the chest. The first thing that our ultrasound beam is coming into contact with in the heart is going to be the right ventricle. The right ventricle is more anterior right here. So the first thing we see on our screen over here is going to be our right ventricle, that's what this is right here. Our left ventricle is right up under that, mitral valve, left atrium, aortic valve, right here, okay? So we're going to start off placing our transducer somewhere around the fourth intercostal space. Each of these transducers has a little indicator mark on them so we know how our beam is being oriented. So we want that indicator mark facing the patient's right shoulder. So our ultrasound beam is cutting the heart in the long axis here, lengthwise. So we're going to start out making big circles. We've already got our ultrasound gel on our transducer. We're going to make some big circles on the chest until we see something moving and until we can kind of see our heart showing up nice and brightly on the screen. Once we see that, then we're going to kind of hone in a little bit and make some smaller circles until we get a fairly nice looking picture. And then to clean it up a little more, we may need to rotate clockwise, counterclockwise, tilt the tail up or down, left or right, something along those lines, so we see both of our valves here opening nicely. All right. Second here, what we've done is we've kind of been able to slice this heart in this view right here, okay? So we've cut out this portion of the heart so you can see how this ultrasound beam is cutting the heart right here, okay? So as I said before, everything with ultrasound, what we see on our screen is somewhat flipped and upside down, okay? So here I'm going to be able to show you, we're going to kind of flip this heart around in the chest so you can see it as it's sitting in the chest compared to as what we're seeing here on our screen. Again, our anatomy is the right ventricle, left ventricle, mitral valve, left atrium, aortic valve. The aorta is kind of coming off this way. Okay, so let's play this video here and you'll be able to see what I'm talking about. There we go. And we spend a lot of time here in our parasternal long axis view of the left ventricle. We do most of our chamber measurements in this view. Now moving forward, the next view we obtain in this parasternal window is going to be the long axis view of the right ventricular inflow. So we call it inflow because blood is flowing into the right ventricle in this view, okay? So anatomically what we're seeing here, we're seeing right atrium, tricuspid valve, and right ventricle here. So flow is coming from the atrium through the valve into the ventricle. So the RV inflow view. So to obtain this, what we're going to need to do with our transducer is simply tilt the tail slightly down up toward the left arm, the patient's left arm here. Now, you may need to move down a rib space or two to get a better view of this, but essentially all we're doing is tilting the tail toward the patient's left arm so we can see more of the right side of the heart down here, okay? You also may need to move a little more medial. You may need to move lateral a little bit. And this goes for pretty much any view that we're obtaining with echo. You may have to move around just a little bit. But again, right atrium, tricuspid valve, right ventricle. This is the anterior leaflet, posterior leaflet of the tricuspid valve. This is the only view typically where we can see the posterior leaflet of the tricuspid valve. And so we're going to play this video here and you will be able to see how we're seeing what we're seeing on our ultrasound machine screen versus what we're seeing in the chest. Here we go. Okay. Moving forward, we're going to go into our parasternal long axis RV outflow view. So with this view, it's the RV outflow view because now we're going to look at the right ventricular outflow tract, the pulmonic valve, and the pulmonary artery. So now we're looking at blood flow flowing out of the right ventricle into the pulmonary artery. That blood flow flows through there into the lungs, then gets oxygenated, goes over to the left side of the heart, and gets pumped out to the body. So in order to obtain this view, what we're going to do, we're going to be roughly in the same spot, but instead of tilting the tail toward the left shoulder like we just did for the RV inflow view, we're going to tilt the opposite way towards the patient's right leg. And then what that's going to do for us is it's going to help us come up here and kind of cut the pulmonary artery right here, as you can see in this view right here. And we're going to flip that around. And there you go. So RV outflow tract, pulmonic valve, and the PA is coming down this way. So over here, we see that exact thing on our screen. This is our RV outflow. This is our pulmonic valve, and then our pulmonary artery flowing this way. Again, you may need to move around a little medial, a little lateral, maybe go up a rib space or two to find this view. But that's essentially what we're seeing. So we're really tilting the tail just the opposite of what we do to find the RV inflow view to see that flow going out through the pulmonary artery. And so those are our basic views for our parasternal long axis window. Now we're going to talk about our short axis. So to obtain this short axis, what we're going to do here is we're going to, instead of our probe or our transducer indicator facing the patient's right shoulder, we're going to rotate roughly 90 degrees to where that indicator is now facing the patient's left shoulder. So instead of cutting it lengthwise, now we're cutting it on the short axis. And then we're going to take the tail of our transducer and we're going to point it down towards the patient's left leg slightly. So we're cutting the area of the base of the heart. So this is the base view in the parasternal short axis, okay? So essentially what we're seeing here, we see a lot of anatomy in this view, so this is an important view for us. So we see the aorta here in the middle, the left atrium, interatrial septum, right atrium, the tricuspid valve is right here, right ventricle is here, RV outflow tract is here, pulmonic valve is here, PA is coming down this way here. So again, a good view to see a lot of anatomy. And that's what we're seeing on our screen. So keeping in this short axis view, next what we're going to do is we're going to kind of travel down the left ventricle here. And so in order to do that, we're going to keep our rotation with the indicator facing the patient's left shoulder. Basically what we're going to do is take the tail of our transducer and we're going to tilt it more toward the patient's right shoulder. And so what that does is it angles our beam down into the ventricle a little bit more, so we're cutting it in the area of the mitral valve. So here what we should see is the anterior mitral valve leaflet on the top, posterior on the bottom. This is our left ventricle here. This is our right ventricle up here. And that's what we're seeing on our screen. Moving forward, now what we're going to do here is we're going to continue angling the tail of our, tilting the tail of our transducer toward the patient's right shoulder. So now we're cutting the ventricle down even further at the level of the papillary muscles. Okay, and so this is a great view for us to look and assess LV function. We can see a lot of different wall segments in this view. We've got our anterior wall, or anterolateral, or inferolateral, inferior wall, inferoseptal, anteroseptal wall, all in this view right here. And so we see our anterolateral papillary muscle right here and our posterior medial papillary muscle right there. In our last view, for our parasternal short axis view, we're going to do the same thing. We're going to continue tilting that tail towards the patient's right shoulder, which angles our beam down the ventricle even further toward the apex. With this view, you may need to drop down a rib space or two, go a little bit more lateral on the patient to really get that apex in well. But we're really taking a good look at this to ensure that the apical portion of our left ventricle is functioning well, okay? So you really just need to get down and see this kind of donut-shaped feature right here, a little tiny circle in there in the middle. That tells us we're right down toward the apex of the heart. That's what we should see there, and here's what we see anatomically. All right, so we've just talked about all of our parasternal windows and the views associated with that parasternal window. Now we're going to talk about our apical windows and the views associated with that. Generally speaking, these apical views are a little bit more difficult to obtain than our parasternal views. The parasternals, you're able to kind of anchor your transducer down on the patient's chest. When you go down to apicals, there's really not a lot to anchor. Sometimes you can use the bed to kind of anchor your hand, your shoulder, and arm down, and then use your finger kind of up around the bottom part of the transducer to kind of anchor your hand to the patient's chest. But it's difficult sometimes because we are kind of moving around on ribs and things like that down there. So it just takes some practice in order to be able to keep that transducer in one spot without sliding down there. So here it's called the apical views because we're looking at the heart from the apex, right? So here's our transducer. Our indicator on our transducer is kind of facing down towards the bed, which would be over here in this area. Okay, and so the first thing our transducer down here comes into contact with is going to be the apex of the heart, right? So if you look over here, think of our transducer being up here looking down. The first thing we see on our screen is the apex of the heart. So again, everything is flipped and turned upside down here. So what we're seeing on the right side of our screen is actually the left side of the heart. So left ventricle, mitral valve, left atrium, right ventricle, tricuspid valve, right atrium, right there. In addition to that, we can kind of see our anterolateral portion of the left ventricle, our inferoseptal, and we get a good view of the apex of the left ventricle in this view as well. And we're going to flip this around here so you get a better idea of how we're seeing this on our screen. There we go. And this apical view is where we spend a lot of time when we're doing our apicals. So we do a lot of measurements here. We can estimate diastolic function here. We look at all the valves here. We do a lot of Doppler, a lot of color Doppler. So this is really where you spend most of the time, this 4-chamber view in your apical windows. Okay, next we're going to go to our 5-chamber. So with our 4-chamber view, we're seeing both ventricles, both atrium. But now with our 5-chamber, what we're doing is essentially we're opening up the aorta in the middle of the screen. The aorta is considered the 5th chamber in this view. So what we're going to do with our transducer, we're going to take the tail of our transducer and we're just simply going to tilt it down slightly towards the patient's feet. Typically what that will do, they will open up our aorta right there in the middle of our screen. This is the best view for us to assess flow going through the aortic valve to ensure the patient does not have mitral stenosis, or with the best view usually as well to look at the severity of aortic insufficiency if they have any of that. Because in this view, we're typically more parallel to flow than any other view. And in order to do spectral Doppler, we want to be as parallel to flow as possible to be accurate. Opposite to that, when we're doing our 2D views, we want to be as perpendicular to the structure as possible to obtain the best 2D views as possible. But with Doppler, it's just the opposite. We want to be as parallel to flow as possible. So in this view, you don't need to worry about seeing all the other chambers really well. Really what we're focused on is seeing this aorta in the middle of the screen and seeing flow going through that aortic valve. And here's how we see it on the screen. Next, we have our 2-chamber. So to obtain this 2-chamber view, what we're going to do is we're going to take our transducer here. As you see, here's our indicator mark right here. Before it was facing down toward the bed. We're going to rotate roughly 90 degrees. That 90 degrees is not a hard and fast type thing. So essentially what you want to do is rotate your transducer counterclockwise until you see the right side of the heart disappear on your screen. Then you know you're in a true 2-chamber view when you see that right side completely disappear. Now again here you may need to slide up a little bit, slide down, medial, lateral, tilt the tail up or down slightly. All of those things can help bring in this image a little bit better. Here we are seeing the anterior wall and the inferior wall of the ventricle, mitral valve here, left atrium right there. So as you can see, our ultrasound beam is kind of just transecting the heart now and completely cutting the left ventricle and leaving out the right ventricle, which is why we're only seeing the left side of the heart. This will give us a good idea when we see this playing live here. There we go. Okay, our last view for our apical windows is going to be our three-chamber view. So with this, again, what you're going to do is you're going to take your transducer, you're going to rotate another roughly 90 degrees or so. Um, and essentially what you're doing is you're rotating enough to where you start seeing that aorta come into the screen on the right side. So here's your aortic valve. This is the aorta coming down this way right here. That's what you want to see. Again, with this, you may need to slide up or down, move medial or lateral, tilt a little bit one way or the other. The biggest mistake people make when trying to get this view going from the two-chamber to the three-chamber is that they drop the tail down, and when that happens, it kind of cuts off the mitral valve. You don't see that opening very well. So just uh, point of advice there is to, as you're rotating, ensure that you keep that tail up while you're rotating around so we can see the aorta as well as the mitral valve in this view. And if you look at this view as well, you can kind of see that we are seeing the same anatomy that we saw in our parasternal long axis view. So instead of it being more parallel to our screen right here or more perpendicular to what we're seeing, it's actually going just the opposite way. It's going parallel to our screen instead of perpendicular like we were seeing in our parasternal long axis view. Same exact anatomy. So this is an anterior septum, this is the infralateral wall, left ventricle, mitral valve, left atrium, aortic valve right here. Okay, so that covers all of our parasternal windows, all of our apical windows. Now we're going to talk about our subcostal or subxiphoid windows. You'll hear that termed either way. Both is perfectly correct. Usually we call them subcostal windows, but you may hear it referred to as subxiphoid. And it's simply because that's what we're doing. We're coming right down below. So here's the xiphoid process and the rib cage here. We're coming right down below that, right at the top of the stomach to get these views. You want to be sure that you're right below that xiphoid process, because if you put any pressure on that, it can be very painful to the patient. So ensure we're down below that. What you want to do is have the indicator facing toward you. You're going to be sitting over here on this side of the patient here, on the patient's left side. You want that indicator facing you. Okay, and now we're going to, the first view we're going to obtain here is going to be our four-chamber subcostal view. So if you look at this, you can see that we're seeing the exact same anatomy that we were seeing in our apical four-chamber view. So, but instead of looking at it from this angle here at the apex, we're now over here looking at it in another angle. This is a great view to see the entire silhouette of the heart, and so we can kind of rule out or rule in any type of pericardial effusion. And you can also oftentimes see pleural effusions in this view as well. So left ventricle here, mitral valve, left atrium, right ventricle, tricuspid valve, right atrium, and here we see our interatrial septum or interventricular septum, and our liver is up here. It's also a good view to interrogate the interatrial septum with color flow Doppler to ensure that there is no color crossing, no shunt or patent foramen ovale. Color flow crossing over from one side of the heart to the other. Okay, so after that, now we're going to talk about our subcostal short axis view. This is not a standard view that we obtain in a normal transthoracic echo, but I wanted to put this in here because it's important that we can oftentimes get this view if we've got a patient with very difficult parasternal windows and we really can't see what we need to see. Oftentimes, if we go down to our subcostal windows, some of these patients have great subcostal views, so we can actually see a lot of what we need to see in our subcostal views. So if you take the transducer, rotate 90 degrees so our indicator is facing straight up now. We're cutting the heart in the short axis again. If you tilt the tail of the transducer slightly away from you, we're right here at the base of the heart, and we're seeing the same anatomy over here as we were seeing in our parasternal short axis base view. Okay, so if we weren't able to see this well there, we can potentially see it well here. So it's always good just to try while we're here. So you've got your aorta in the middle of the screen here, left atrium, right atrium, tricuspid valve, right ventricle, pulmonic valve is over here. But we really only obtain this if our short axis base views are suboptimal. All right, moving on, we've got our subcostal or subxiphoid IVC view right here. So our inferior vena cava. So what we're going to do, just like we were looking at with our short axis view in the subcostals, we're going to take our transducer, we're going to rotate it 90 degrees so our indicator is facing straight up, and we're going to take the tail and tilt it towards us slightly so it angles our beam right in this area of the heart so we're catching the inferior vena cava. Here's what we see on our screen over here. So here's your IVC. Here's dumping into the right atrium right here. Oftentimes you can see the hepatic vein right here. This is the liver up superior to the inferior vena cava there. This is a very important view for us in echo because we use this view to estimate right atrial pressure. And our right atrial pressure goes into our calculation when we're calculating pulmonary artery pressures. So this is a very important view. So we base that on whether or not the IVC is normal size and whether or not it collapses upon inspiration. So as we breathe in, our interthoracic pressure changes, and this is a low pressure system. So with that change, this low pressure system should collapse briefly as we take a deep sniff in. If it doesn't collapse, that gives us an indication that right atrial pressure is elevated. And so we have numbers that we can associate with that. So it's a very important view for us. And there we go. You can see here's the IVC right in that area there. Okay, that's it for our subcostal views. The last window that we're going to obtain is going to be our suprasternal notch window. So what we're going to do is we're going to take this transducer. We're going to come all the way up here right at the bottom of the neck. You will find a little notch there, kind of right in between both clavicles there. You're going to have your patient kind of lean their head back, tilt their chin back. Your transducer indicator needs to be facing right towards the patient's chin, and you're going to slightly rotate clockwise and tilt the tail away from you just a little bit most of the time to obtain this view. So what we're seeing here is we want to be able to see the arch of the aorta, and then we want to be able to see the descending portion of the aorta as well. Oftentimes you can see these branches coming off of the aorta here. The brachiocephalic or innominate is the first one. The left subclavian artery is the second one. And the last one here is, the middle one is the left common carotid. And the last one is the left subclavian artery coming off right there. So we typically can see at least 2 or 3 of those great vessels coming off of the aorta. And we always put color flow Doppler on in this view. Really what we're looking for here is good smooth flow out through the aorta. We take a close look at this area right here, which is considered the isthmus of the aorta. If their patient does have any type of coarctation, it usually happens right here in this area. So we take a good look at that. This little circle we're seeing right here is going to be the pulmonary artery in a short axis, and then the left atrium is up under that. And there we go. And that generally concludes all of the standard views that we obtain during a full transthoracic echocardiogram. Now, in this presentation, we really just focused on the basic views. In a normal full transthoracic echo, we're going to put color on the valves in every view. We're going to color, pulmonary veins and pulmonary artery and the aorta. We're going to do that in pretty much every view. We're going to use spectral Doppler in every view as well. We're going to assess diastolic function with tissue Doppler. So a lot of the things that we do that are incorporated in a full echo, but for the purposes of this presentation, we were just talking about obtaining these basic views for a transthoracic echocardiogram. These are all of my references, and I thank you for your time.